जब एक पेशेंट जॉइंट पेन की शिकायत लेकर आता है तो हम सिर्फ दर्द के आधार पर डायग्नोसिस नहीं कर सकते। पेन इज ऑफन अ वेग इंडिकेटर। क्या ये मसल टेयर है, कोई पिंच्ड नर्व है या जॉइंट इंस्टेबिलिटी? पेन अकेला ये फर्क नहीं दिखा सकता। असेसमेंट का सही रास्ता आइसोलेशन है। स्पेशल टेस्ट्स आर engineered to place maximum mechanical stress on one highly specific anatomical structure while keeping the surrounding tissues and joints relaxed. Looking at this Yergason's test diagram, you see how we isolate the long head of the biceps. By stabilizing the elbow at 90 degrees and resisting forearm supination, the tendon is forced to engage. If compromised, it literally pops out of the bicipital groove. Mastering these mechanics allow you to move beyond general reports of pain and differentiate between specific anatomical failures. You are applying objective physical stress to confirm or rule out an injury.
In the drop arm test, the patient slowly lowers an arm abducted to 120 degrees. Contrast that with the empty can test below. The arm is abducted 90 degrees, shifted 30 degrees forward. The patient internally rotates to thumb down and resists downward pressure. Each test looks for a different failure. A positive drop arm test typically means the patient physically cannot control the limb's weight, suggesting a full rupture. In the empty can test, the indicator is localized pain or weakness, specifically within the supraspinatus tendon. The Neer and Hawkins-Kennedy tests focus on impingement rather than muscle strength. These movements are designed to narrow the subacromial space. By forcing the shoulder into internal rotation and flexion, we are checking if structures inside that space are being physically pinched. These small shifts in the angle of the arm determine your clinical finding. A slight change in degree dictates whether you are loading a specific tendon or compressing a joint space. Students often find it difficult to distinguish between the tests for tennis elbow and golfer's elbow, but the difference is in the mechanical load. This lateral epicondylitis section details Cozen's test. With the elbow at 90 degrees and the forearm pronated, the patient must resist wrist extension and radial deviation. This force specifically targets the common extensor origin on the lateral side of the elbow. These side-by-side anatomy diagrams show the opposite logic for medial epicondylitis. Instead of resisting extension, we passively supinate the forearm and extend both the elbow and wrist. This stretches the common flexor origin on the medial side, targeting the lateral exterior through resistance, while stretching the medial interior through supination, creates a clear biomechanical logic for distinguishing these two pathologies. When we shift from musculoskeletal tests to nerve isolation, the goal changes. We aren't looking for strength or stability, we are looking for very specific sensory feedback. This Phelan's test diagram shows how holding the wrists in maximal flexion for 60 seconds compresses the median nerve. A positive sign isn't just pain, it's tingling or paresthesia that follows the exact nerve distribution map shown in the palm. Let's try a quick recall. A patient has thumb-side wrist pain. You ask them to tuck their thumb into a fist and then push the wrist down toward the floor. What test are you performing? As you can see at the top of this page, that is the Finkelstein test, used to identify de Quervain's tenosynovitis. Knowing exactly what clinical indicator to look for, whether it's a sharp pain, a loss of pressure, or a tingling sensation, is what ensures an accurate assessment. This SLAP prehension test demonstrates why depth matters. Standard bicep tests might miss a labral issue, but by alternating between pronation and supination during horizontal adduction, you can isolate whether the pain is coming from a superior labral tear. We consolidate these tests into a diagnostic matrix, organizing your assessment by joint location and suspected pathology. By filling the matrix with tests we've covered, like placing the drop arm test under shoulder/muscular and Phelan's under wrist/nerve, you create a structured clinical reference tool. Take a screenshot of this completed matrix. Once you understand the categories, practice these exact hand placements and resistance angles on a peer to build the physical muscle memory required for the clinic. Precise physical execution combined with a structured mental framework allows you to evaluate complex physiological signs with clinical rigor. This is the foundation of evidence-based manual therapy.